Okay, so hi guys, welcome everyone back to the Physics Wala Med. And in the Read Helsin series, we are continuing the clinical case discussion as well because sabko pata hai, merely knowing the theory is not enough to deal with the MBBS preparation. So we are going to discuss the cases, at least one case per month. So today we have Dr. Urvashi with us. She will be presenting a case from the cardiovascular system. Her presumed diagnosis is aortic stenosis. So let us see if we agree with that as we proceed with the case discussion. So, Dr. Urvashi, you can take us through the case.
Sure, sir. Hello. So today I'm going to present a clinical case on aortic stenosis. So first of all, starting with the patient, we received patient Mr. Ramesh Kumar. He is 60 years of age, a male, and he's a retired school teacher, lives in Pune, and his date of admission was 17th of July, which was yesterday, one day back.
Okay.
Sir, the chief complaints that he said. So, first of all, was exertional chest pain for 8 months,
Okay.
breathlessness, or in Hindi, like he said it, सांस फूल जाती है for
Okay.
the past 4 months, and 2 episodes of syncope as well in the last 1 month.
Okay. So just let me stop you there. So students, she has presented the chief complaints. There are three major complaints: chest pain on exertion, shortness of breath, and 2 episodes of syncope. Now, whenever we are listing the chief complaints, we should always make it a point to list them in chronological order. Matlab kya? The oldest complaint should be listed on top and the newest complaint should be listed at the bottom. There should be a chronological order which she has perfectly followed. The dyspnea, the chest pain was of 8 months, dyspnea 4 months, and 2 episodes of syncope in last 1 month. So it is arranged in chronological order. So Dr. Urvashi, I have a question. Now,
Yes, sir.
when patients open up and tell their symptoms, they may sometimes open up a story of 8 years, 10 years. Now, what should go into the chief complaints and what should go in the past history?
Sir, I believe that the main symptom that brought him here in the first place, that should be in the chief complaints, or any complaint that has been ongoing could also be taken in this. But any pre-existing conditions or anything that is not aggravated right now can be put in the past history.
Okay, so good. So she made a very important point. The best way to decide what goes into the chief complaints and what should go into the past histories, ask the patient when he starts talking to you about the symptoms, ask him what brings him to the hospital now. Generally, they will open up of the complaints that are bothering them currently. They may be new onset symptoms or they may be exacerbation of a past symptom, like an ongoing symptom which is now worsened. So whatever that brought him to the hospital should be part of the chief complaint. And then anything you feel is not related to the current symptoms can go into the past history. Most of the comorbidities like diabetes, hypertension generally land up in past history. Okay, I think we can proceed now.
So, sir. So the history of presenting illness or HOPI. So this patient, first of all, he developed chest pain on exertion, like I said, for the past 8 months.
Mhm.
And he described it as tightness in the chest. And he also described a radiation towards his neck.
Okay.
And this was relieved by rest. मैं आराम करता हूँ तो सब ठीक हो जाता है, पर गले तक जाता है and so on.
So does it fit the classical description of angina?
Sir, yes, I think it does.
Yeah, so the anginal chest pain is usually retrosternal. It is not sharp. The patient doesn't say that it's very severe pain or it feels like someone is stabbing me. They generally say it is a squeezing type of pain or some kind of tightness, which is what we are seeing here. The anginal pain gets referred often to neck, shoulders, epigastric region. So here there is radiation to the neck. And anginal pain may get relieved by rest or taking the sublingual nitrates. So the description fits into angina. So let us presume that this patient is going through episodes of angina from 8 months. Okay, let's proceed to the other complaints.
Yes, sir. Apart from that, he had breathlessness, like he said, which he developed gradually over time. And based on his history that he had described, I could see that it had progressed from NYHA class 1
Mhm.
to NYHA class 2 over a period of 4 months.
Okay, good. So another observation, generally when we are still in the history of presenting illness, we are better to stick to the patient's words instead of making our own interpretations. So instead of documenting it down as progression from NYHA class 1 to class 2, we could write down how his life changed or how his physical activities changed over this 4 months period. Like, okay, 4 months back he could do this, now he can't do this. After that, if examiners prompt you, then you can say, sir, I would count this as a progression from NYHA class 1 to class 2 or class 3, whatever it is. So sticking to patients' words is one of the important things that we should restrict when we talk about the history of present illness. Okay,
Sure,
let's
sir.
get to the next part of it.
The next part was syncope. He described that he experienced two episodes of syncope while he was walking briskly, and each of them was very spontaneous, had spontaneous recovery, and each of them lasted less than a minute.
Okay, so few points here. So one of the complaint is angina, as we concluded. So can you tell me few causes for angina?
Sir, angina could be caused because of some, mainly it is caused because of the ischemic heart disease, I think,
Yeah.
coronary artery diseases and like MI. So I think that is one of the major causes. The second one could be,
Other than the coronary artery disease, what else can cause angina?
sir, something else I think could be the hypertrophy of left ventricle could cause this, for example, due to hypertension or due to valvular heart disease like this one.
Good. So students, the main mechanism is the angina is a symptom of myocardial underperfusion. Myocardium is not getting the sufficient blood supply. And when I say sufficient, it means two things. Myocardium needs some amount of blood supply. Coronaries are capable of giving that blood supply. Now, if coronaries become narrowed or blocked, they cannot give that blood supply. So myocardium is not getting as much as it wants. So we experience ischemia and thus we get angina. But sometimes what happens is your coronaries are fine. They're able to give the normal blood supply, but myocardium wants more than normal. Like in case of left ventricular hypertrophy, the muscle mass is more. So it wants more blood supply now. And the coronaries are not able to increase their blood supply. So then we can end up with angina. So that LVH can happen in hypertension, aortic stenosis, hypertrophic obstructive cardiomyopathy. All these patients can present with angina. So please don't think that angina is always equal to coronary artery disease. There are also non-coronary causes for angina. Okay. The next one you said is patient was having shortness of breath. So can you tell me
Yes.
few respiratory causes and few cardiovascular causes for shortness of breath?
Sir, for shortness of breath, cardiac causes could be something like heart failure, could be valvular diseases as well. Anything that could be affecting the left side of the heart could lead to that. Coming to respiratory causes, if it is chronic, it could be something like pulmonary edema. If it is acute, we could suspect more of pneumothorax and these conditions.
Okay. So most common respiratory cause for shortness of breath is pneumonia. Like we saw plenty of COVID patients, a lot of pneumonia patients coming to hospital with acute shortness of breath. The most common cause for chronic shortness of breath is COPD. Apart from that, attacks of asthma can cause acute shortness of breath. Aspiration pneumonia can cause pneumothorax, pleural effusion. So these are all causes, respiratory causes for shortness of breath. Cardiovascular, we should, as you said, mainly think of the left side of the heart. If I have aortic stenosis, mitral stenosis, mitral regurgitation, or aortic regurgitation, I can end up with the pressure buildup in the pulmonary vasculature, resulting in classical dyspnea. Mainly starts with the exertional, and as time progresses, it becomes rest dyspnea. Okay, so now thinking about angina and shortness of breath, do you think we're dealing with the right side of the heart or the left side of the heart?
Sir, I think it is the left side of the heart.
Good. Okay. Now, the last complaint was syncope. Can you tell me
Yes.
few causes for syncope?
So syncope, I think, could be due to different causes. It could be like the most common one that I know of is vasovagal syncope.
Okay, have you
Then,
experienced it?
No, sir, but one of my friends did.
So we have witnessed, all of us have witnessed the syncope happening in front of our eyes for sure. Vasovagal syncopes. Okay.
Yes. Sir, the next one I think could be cardiogenic cause for syncope, like third degree heart block, like
Mm.
even aortic stenosis. One of the prominent symptoms is syncope. Then it could also be neurogenic apart from that.
Okay, good. So
Yes.
syncope basically happens when there is reduced perfusion of the brain, sudden decreased perfusion of the brain. So it can happen because of cardiovascular as well as non-cardiovascular cause. The most common cause is vasovagal syncope, which is very common. So I have a question now. The patient experienced two episodes. You concluded it as syncope. But what if those episodes were seizures? How do you differentiate between syncope and seizures?
So he said there was spontaneous recovery, so that could be one point.
Okay, so can bowel and bladder continence, incontinence during that episode of loss of consciousness help you to differentiate between seizures and syncope?
Yes, sir, definitely.
Okay, so the
I
point
think.
is bowel and bladder incontinence even may happen in syncope, less frequent.
Oh,
So if you have it, it is more likely to be seizure, but it can happen in syncope. So that point does not help us to rule out much. So few points that help us to rule out or differentiate between the syncope and seizures is that patients with seizures, especially those who have generalized tonic-clonic seizures, which is the most common seizure, generally will have post-ictal confusion and they will have severe post-ictal fatigue. So they go through this
right.
post-ictal phase, which is generally not so common in syncope patients. So they recover spontaneously. After that, they are fully all right. They don't experience severe fatigue or they won't be confused. They are back to normalcy. But clinically differentiating between absence attacks or atonic seizures and syncope is very difficult. So whenever there is a doubt, we might have to go for a EEG evaluation.
Okay.
Okay, so now looking at the three causes and whatever differential diagnosis possible causes we discussed, what are the principal differential diagnoses that comes to your mind now?
Sir, for now, I think angina, breathlessness, and syncope do lead to uh, aortic stenosis, but I can also maybe consider ischemic heart disease. We could also think of heart failure.
Okay. Yes, good. So heart failure can be associated with reduced cardiac output. It can lead to syncope. It can lead to angina. It can lead to the shortness of breath. Good. And then
Yes.
any condition where cardiovascular reason is there for reduced cardiac output, we may end up with these symptoms. But yes, looking at the age, we have few important differential diagnoses. I would rate ischemic heart disease on top and then aortic stenosis. Okay, so let's proceed with the rest.
So coming to the past history, I asked him, he has no known history of hypertension or diabetes or tuberculosis. He
Okay.
also mentioned कि कभी life में heart का कोई problem नहीं हुआ, तो
Okay.
no previous cardiac illnesses or any interventions related to that.
Okay. So, is there any relevance of tuberculosis to cardiovascular diseases?
Sir, yes, I think indirectly tuberculosis, like directly also tuberculosis can lead to effusion, cardiac effusion,
So, tuberculosis can
pericardial
lead to
effusion,
the
sorry.
tuberculous pericardial effusion, and the other thing is in
Yes.
India, this is tuberculosis is the leading cause for the chronic constrictive pericarditis.
Yes, sir.
Can this be a case of constrictive pericarditis?
So for constrictive pericarditis, I'm not so sure.
Okay, constrictive pericarditis is unlikely because when constrictive pericarditis happens, it affects the right side of the heart more than the left side of the heart. All of our symptoms are related to left heart. So if patient had raised JVP, hepatomegaly, ascites, I would have thought of right side of the heart, then constrictive pericarditis would become a differential diagnosis. At this point of time, I'm not thinking about it.
Okay, sir.
Okay, proceed.
So the next one is family history. So family history, he did not have any kind of valvular heart disease or sudden cardiac death in the family.
Okay, so can you tell me few valvular heart diseases where family history is often strong?
So, a few of them, I think HOCM is has a prominent family history, hypertrophic obstructive cardiomyopathy. Then the other ones, I think even ischemic heart disease has some genetic basis.
Okay, so apart from these two, you can also think of congenital bicuspid aortic valve, which is one of the cause for aortic stenosis in young individuals, which is an autosomal dominantly inherited condition. And then there are few non-valvular cardiac conditions where family history is relevant. For example, there is arrhythmogenic right ventricular dysplasia or ARVD, then congenital long QT syndromes. So there are few other conditions which are not valvular, but still cardiac conditions where family history is relevant. Okay. Why did you ask about sudden cardiac death in the family? What was in your mind?
Sir, I think to rule out any of these genetic conditions.
Yeah, so 2 points students have to remember. One is the most common cause for sudden cardiac death overall, without looking at the age. All the age group put together is ischemic heart disease. हम बहुत बार सुनते हैं this story कि सोने गए थे दादाजी और सुबह जब हम उठाने गए तो he was no more. So he had a sudden cardiac death in the sleep itself. And reason क्या था? Generally people say heart attack हुआ था. Basically they had an episode of massive MI. So IHD is the most common cause for sudden cardiac death, and which family history is an important factor. Second is HOCM. HOCM is the most common cause for sudden cardiac death in young individuals and athletes. So again, that's why we should be asking about any family history of sudden cardiac death. Okay, proceed.
So coming to his personal history, I asked about diet. So he said he had a mixed diet. Then coming to appetite, appetite has been normal. There has been no change in his appetite. Bowel and bladder function have been normal as well. He
Okay.
has been getting adequate sleep and he has no addictions like smoking or alcohol.
Okay. So two things here. Is diet having anything to do with the cardiovascular diseases?
Sir, definitely a high fat diet has is a risk factor for atherosclerosis and coronary artery diseases and so on.
Okay. Any nutritional deficiency is known to cause heart failure?
Yes, sir. Berry
Good.
is known to cause.
And then regarding the addictions, is there any relationship with cardiovascular disease and alcohol?
Yes, sir. So alcohol is related to, I think, RCM, which is restrictive cardiomyopathy.
Not restrictive, the dilated cardiomyopathy.
Oh, I'm sorry. It is related to the dilated cardiomyopathy, and cocaine is also related to that. Apart from dilated cardiomyopathy, I think it is also related to holiday heart syndrome.
Good. So what is it? What is holiday heart syndrome?
Sir, after an episode of binge drinking, the patient develops atrial fibrillation.
So binging with alcohol, especially large dose of alcohol, is a risk factor for development of atrial fibrillation. Typically, during the beginning of holidays, people binge, and then next day they start palpitations and they come to hospital. That's why it's called as holiday heart syndrome. And regarding the dilated cardiomyopathy, I always tell if you have an alcoholic friend when they are intoxicated, right? They speak as if like they have a big heart, like सब कुछ तेरे लिए कर दूंगा, सब कुछ लुटा दूंगा. In reality, their left ventricle is also becoming big. So उनके हार्ट सिर्फ बातों में बड़ा नहीं होता है, in essence अंदर भी हार्ट बड़ा हो जाता है. That's classical dilated cardiomyopathy because of alcohol.
सर
Okay, so
एक्चुअली ये बहुत अच्छा तरीका है याद करने का बिकॉज आई ऑल्सो गॉट कंफ्यूज्ड अब मुझे याद रहेगा.
yeah, so guys, remember whenever you're taking personal history, make sure you get a detailed history of alcohol consumption because जो patient आपके सामने heart failure के साथ है, it need not always be because of ischemic heart disease. Sometimes it can be because of dilated cardiomyopathy due to alcohol. Okay, one more addiction we missed: smoking. Does it have anything to do with cardiovascular disease?
Yes, sir. Smoking is one of the most one of the biggest risk factors for heart disease.
Smoking is the strongest acquired risk factor for heart disease. Whatever you get from the family inherited, that is there, but among the acquired risk factors, smoking is the strongest acquired risk factor. In fact, the most common cause for death in COPD is not COPD, it is coronary artery disease. Means even before COPD could kill you, the coronary artery disease because of your smoking generally kills. Okay, I think we can proceed.
Okay, sir. Coming to general examination, his build and nourishment seemed average. On physical examination, there was no pallor, there was no cyanosis, there was no clubbing.
Okay,
Then
so, in what cardiovascular disorders you can get cyanosis and clubbing?
the cyanosis and clubbing, I would suspect when there is like congenital heart diseases,
Mainly
cyanotic.
the congenital cyanotic heart diseases. Basically, what happens there is mixing of blood from the right side of the heart, which is deoxygenated, into the right side of the left side of the heart. From right to left, if there is flow of blood, that can result in deoxygenated blood coming to the left and then going to the tissues, giving rise to cyanosis. Okay, and the same conditions that cause cyanosis, they also increase the risk of developing the clubbing. Okay.
Coming to JVP, JVP was normal.
Okay.
Then pedal edema was absent. There was no pedal edema. The pulse, when I noticed, it was 70 beats per minute, but it was low volume and slow rising.
Okay.
The blood pressure was 110 by 70 millimeters of mercury, and respiratory rate was 18 per minute.
Okay. So now we concluded from the symptoms that this patient is having a pathology involving the left side of the heart. Okay. And now,
Yes.
once you notice that the JVP is normal, can you tell me what is happening to his right side of the heart? Is it involved because of the left heart or probably not?
Sir, since JVP is like an indicator to tell us about the right side of the heart, and since it is normal, I believe that there has been no progression towards the right side of the heart yet.
Okay, good, good. Regarding your pulse, so you said that the volume of the pulse is low and it is slowly rising. Is there
Yes,
a
sir.
classical term used to describe this pulse?
Sir, anacrotic pulse?
You can call it as anacrotic, but anacrotic only explains the low volume pulse.
Yeah.
The low volume, slow rising pulse combined, we call it as pulsus parvus et tardus. Tardus means
Oh,
slow and parvus means small. So amplitude small hai, rise slow hai. All put together, it's called as pulsus parvus et tardus. Any idea in what condition we get this so-called pulsus parvus et tardus?
sir, in aortic stenosis?
We get it in severe cases of aortic stenosis. Do you have any idea what could be the mechanism behind this low volume and slow rise of the pulse in AS?
Sir, I'm not so sure about the mechanism behind it.
The main mechanism is in aortic stenosis, the valve opening is very narrow. So when left ventricle wants to eject the blood, because of this narrow opening, the amount of blood that can escape from the ventricle to aorta is reduced. And the peak of the pulse is directly proportionate to the stroke volume. So if I eject more, I will have a large volume pulse. If I eject less, I will have less volume pulse. Now narrow opening means we will have smaller stroke volume. So volume, the amplitude of the pulse will also be small. And because of the opening is narrow, the blood is slowly escaping the left ventricle to reach the aorta. So the pulse will also rise slowly. So that's why we call it as pulsus parvus et tardus. What is the best location to look for the character of the pulse? Rate you can calculate anywhere as such, but for the location, for the character of the pulse, to see the
So the
amplitude.
carotid?
Yeah. So whenever you have to comment on the character of the pulse, you should be palpating the carotid. Can I palpate both the carotids simultaneously?
Hmm, I'm not sure, sir.
We should never palpate both the carotid simultaneously, because when we try to palpate both the carotid simultaneously, we cut off the blood supply to brain, so we can induce an artificial syncope in the patient, so patients can lose consciousness. And if they already have low cardiac output or a compromised blood flow to the brain, it can also induce strokes. So we should be cautious, one carotid at a time, not both simultaneously.
Okay, sir.
Proceed.
The next that I did was systemic examination. In that, the first system was the cardiovascular system.
So just let me stop you there. So students, whenever you are
Yes.
commenting about the systemic examination after your general examination, make sure that you start with the system where you're thinking your major differential diagnosis comes from. So in this case, like shortness of breath, if that was the only complaint, then I could have thought of respiratory disorders, cardiovascular disorders, and other systemic diseases. So among them, which system is most likely to be causing the disease is my thought. That system will be first examined and presented, then the next most important system, then the next most important system. So here she is strongly thinking of cardiovascular disease. So that's why she is starting with the CVS examination first. Okay, we can start.
Yes, sir. So first of all, on inspection, there were no visible pulsations or any deformities over the precordium.
Okay.
Then coming to palpation, the apex beat in the fifth intercostal space was palpated.
Mhm.
Then mid-clavicular line, like there was heaving in nature, and there were no thrills present. Then coming to percussion, the cardiac borders were normal, and through percussion there was no hypertrophy.
Mhm.
And auscultation, there were soft S2 sound.
Mhm.
Harsh ejection systolic murmur was best heard at the second intercostal space radiating to the carotid. Sorry, the right second intercostal space.
So let me start with the inspection. So you said you looked for visible pulsation. So can you comment on few
Yes.
important visible pulsations which can help us to go towards possible diagnosis?
Sir, one of the pulsations could be the suprasternal pulsation. It
Good.
could be because of an aneurysm of the arch of aorta.
Good.
The second one could be because of the aneurysm of the abdominal aorta in the epigastric region.
Okay. Good. Mhm.
And epigastric could also be because of tricuspid regurgitation.
Mhm.
Then any other, I think left parasternal region also, if there is any right ventricular hypertrophy.
Good. Yeah.
Yes, right.
So you can have visible pulsations in the neck, mainly carotids, in patients with hyperdynamic circulation or aortic regurgitation. So in AR, you call it as dancing carotids or Corrigan's pulse. Then you can have the suprasternal, as you mentioned, in patients with the arch of aorta aneurysm, but you can also get it in aortic regurgitation. In the epigastric region, abdominal aortic aneurysms, and the tricuspid regurgitation primarily causes liver pulsations, which can be reflected to the epigastric region as well. And in the left parasternal region, the tricuspid regurgitation and right ventricular hypertrophy can lead to the visible pulsations. Pulmonary hypertension can lead to visible pulsations in the left second intercostal space. So these are some potential clues for further evaluation. Okay. Then you mentioned that the apex beat is in the fifth intercostal space on the midclavicular line.
Yes.
That's a normal location of the apex beat. If the apex beat is displaced, what does that indicate?
So if the apex beat is displaced from here, then it means that the left ventricle is hypertrophic or dilated.
Okay. So what type of hypertrophy is likely to cause the apex displacement? Because there are two types, concentric and eccentric.
Sir, eccentric.
The concentric, the muscle mass gets added more inwards. So the outer dimension of the left ventricle may not change much. But in case of eccentric, the muscle mass is added more outwards. So that tends to lead to the outer dimension of the left ventricle increase much. So whenever you think of the apex beat displacement because of the left ventricular change, you should think of dilation of the left ventricle or eccentric hypertrophy. The conditions where you have concentric hypertrophy, you may not have much displacement of the apex beat. So if this is a case of AS, in AS we get concentric hypertrophy. So we're not expecting the apex beat to be displaced. And as per expectation, it is in the normal position. Regarding the percussion, is it important to do percussion for a cardiovascular case?
Sir, I think it is.
So today we don't consider it as very relevant because basically in the percussion we're trying to delineate the borders of the heart. But there are various other ways for us to understand the change in the dimensions of the heart. For example, if there is left ventricular eccentric hypertrophy, or if there is dilated left ventricle, we will already have the displacement of the apex beat. So from there itself, I can gauge that patient may be having either eccentric LVH or dilated left ventricle. So then I don't need to really percuss. And the atrial enlargements are generally not easily figured out, especially left atrial enlargement on the percussion. So that's why today we do not consider percussion as a very relevant part of the cardiovascular examination. Many teachers don't want it, but you should always write it down, because there are some old school teachers still expect you to write it down. So they may interrupt and they may not accept if you say that, sir, percussion is not relevant. But once you come to the practice, you know that doing cardiovascular percussion is just waste of time. Okay, so coming to auscultation, we'll go to the murmur later. But you said that this murmur was heard on the right second intercostal space. So can you tell me from which valve this murmur is coming from?
Sir, it is coming from the aortic valve.
Yeah, so the right second intercostal space is aortic area. The left second intercostal space is pulmonic area. Left lower parasternal region is the tricuspid area, and wherever is your apex beat is your mitral area. So if the murmur was coming from the apical region, then it is probably a mitral valve pathology. If it was coming from the left second intercostal space, then it is probably pulmonic valve pathology. Now that it is coming from the right second intercostal space, it is pointing towards aortic stenosis. So is this observation consistent with our initial diagnosis based on the history, or it is incongruent with it?
Sir, it does align with our provisional diagnosis.
So as of now, the symptoms, the history, and the examination findings are all pointing towards the possible aortic stenosis. Okay. So what kind of murmur we are expecting in aortic stenosis?
Sir, an ejection systolic murmur.
Okay. So can you describe it a little more about the murmur? How does it sound?
Sir,
Yeah.
I'm not sure.
So this murmur has a characteristic diamond shape, in the sense the intensity of the murmur, once it starts, goes on increasing and then goes on decreasing till the murmur disappears. So we call it as crescendo decrescendo murmur. So in an aortic stenosis patient, we get this classical crescendo decrescendo ejection systolic murmur, best heard in the right second intercostal space. So whenever we describe the murmur, we should describe where is it best heard. First, describe the murmur. What is the nature of it? Whether it is systolic, diastolic, mid systolic, late systolic, early, late, whatever, or pan. After that, try to describe how does it sound. Here we are using the word harsh. In case of mitral stenosis, the murmur is very faint, so we call it as rumbling murmur. We can also use different terms to describe different murmurs. So here we can stick to harsh. So we get a harsh ejection systolic. The intensity of the murmur goes on increasing and decreasing. So I will use the term crescendo decrescendo murmur. After this, we should describe where is it best heard. Here it is in the right second intercostal space. After that, we should describe where all or what other areas this murmur gets referred to or conducted to. So you have described that this is getting radiated to the carotids. After that, we should also comment about what happens to the murmur intensity when we do dynamic auscultation. In the sense, when we try to do maneuvers which increase the venous return or decrease the venous return, what happens to the murmur intensity, whether it increases or decreases. At an undergraduate level where you're just beginning to present the cases, at least be able to write whether it is soft or harsh, whether it is systolic or diastolic, which area it is best heard, and what other areas or what other locations it is radiating to or referred to. So commonly aortic stenosis murmur gets referred to carotids. The reason for that is the sound gets carried in the direction of flow of blood. So blood is flowing from left ventricle to aorta, and aortic valve obstruction creates the murmur. So from the aorta, the murmur or the sound travels along the carotids. That's why we can hear it on the carotids as well. Okay. Now, can you tell me in what other conditions you can get systolic murmurs apart from aortic stenosis?
Sir, pulmonic stenosis,
Yes.
pulmonary stenosis,
Yes.
then even in HOCM,
Yes. Good.
um, yeah.
So in all these three you listed, we get the ejection systolic murmur itself: pulmonic stenosis, HOCM, and aortic stenosis. Pulmonic stenosis, this is unlikely case of pulmonic stenosis because if I had pulmonic stenosis, I'll have right-sided symptoms, not the left-sided symptom. Patient would have come to me with raised JVP, hepatomegaly, ascites, and those features. Second, the murmur will be best heard in the pulmonic area, which is left second intercostal space. So pulmonic stenosis is ruled out. But how do I differentiate between HOCM and aortic stenosis? Because both will present with a murmur in the right second intercostal space.
Sir, HOCM, one of the main features is that on different maneuvers like Valsalva maneuver or even standing, the HOCM murmur, it increases.
Yes.
And the aortic stenosis murmur, it is completely opposite. It will decrease.
Yes.
And vice versa with squatting, for example.
So in HOCM is a classical exception to the rule of auscultations. So majority of the murmurs increase in intensity when you do maneuvers which increase the venous return. Because more the blood, more flow across the narrow wall, more turbulence, more is the murmur. So if I squat, I contract my calf muscles, squeeze and push all the blood from the calf veins towards the heart. So venous return increases. So if it is a murmur of aortic stenosis, it should increase. But HOCM is a classical exception. Other exception is mitral valve prolapse. So HOCM and MVP murmurs decrease in conditions where there is increased venous return and vice versa is true. Whenever there is decreased venous return, these murmurs increase in intensity. So those points help. Another point probably you overlooked, the age of presentation. HOCM typically presents in middle-aged and aortic stenosis most commonly presents in elderly. So in this case, we are dealing with a 60 plus. So it is less likely to be HOCM, more likely to be aortic stenosis. Okay, good. Proceed.
Yes. Coming to the respiratory system, the bilateral air entry was normal. There were no additional sounds.
Okay. So if it was a case of heart failure, what sounds you would have expected on respiratory examination?
Sir, on respiratory examination, if it was heart failure, then due to pulmonary edema, there would be dullness on percussion, for example,
Yeah, see,
and
the often heart failure is associated with some degree of pleural effusion. So wherever there is effusion, you will get the dullness on percussion. On auscultation, the pulmonary edema gives rise to classical crepitations or
crackling.
crackles. Usually
Yes.
at the basal levels, as the severity increases, the level of crackles also goes on increasing. Okay, proceed.
Coming to the examination of the abdomen, it was soft, non-tender. There was no hepatosplenomegaly to be noted or no free fluid.
Okay, so what cardiac conditions can lead to hepatomegaly and even the free fluid or ascites?
Sir, the right-sided conditions, for
Yes.
example, like you mentioned, pulmonary stenosis.
So any chronic right heart pathology can result in hepatomegaly because the congestion, just like how left heart disease leads to congestion of the lungs, right heart disease leads to congestion of the liver. So eventually there is development of portal hypertension and it can lead to ascites as well. So please, students, don't think that someone with hepatomegaly and ascites is always having the alcoholic CLD. Even right heart diseases can present with portal hypertension. We can have hepatomegaly as well as the ascites. So you can think of pulmonary valve pathologies, tricuspid valve pathologies, restrictive cardiomyopathy, constrictive chronic constrictive pericarditis. All of them affect right side of the heart. So we can end up with all these features. In what conditions you get this pulsatile hepatomegaly?
Sir, pulsatile hepatomegaly, tricuspid regurgitation.
That's a very important MCQ also repeatedly asked in the past. The mechanism is that when you have tricuspid regurgitation during systole, when right ventricle contracts to eject the blood to pulmonary artery, some amount of blood goes to the right atrium. So suddenly there is a buildup of right atrial pressure during systole. So that pressure gets transmitted to the inferior vena cava through inferior vena cava to liver. So you can feel that regurgitation happening in the heart in the liver itself. So whenever examiners ask you where do you get this pulsatile hepatomegaly with respect to cardiovascular diseases, always mention tricuspid regurgitation, and the same pulsation can be reflected to the epigastric region. That's why sometimes we can have visible pulsation in the epigastric region. Okay, proceed.
Yes, coming to the CNS, the patient was conscious, he was oriented. There were no focal neurological deficits as such.
Okay, proceed.
Coming to the differential diagnosis that I could think of based on the symptoms, based on the examination, were aortic stenosis. And since considering his age, it could be degenerative or calcific, most likely. The other thing could be hypertrophic obstructive cardiomyopathy, but like we already discussed, his age and also the murmur do not fit into this. Then coronary artery disease with exertional angina was also one of my differentials. Then aortic sclerosis was also one of my differentials.
Okay. So those who don't know what is aortic sclerosis, it is nothing but a pre-stenosis stage. So with aging, our aortic valve gets degenerated and calcified. When it is severely narrowed, it creates a gradient between aorta and ventricle. Then we call it as aortic stenosis. So before it creates a gradient, we call it as sclerosis. So we have a normal aortic valve, then there is atherosclerosis, then calcification, then aortic sclerosis, and then once there is a significant gradient, then it is aortic stenosis. So it is like just like how you have pre-diabetes and diabetes, aortic sclerosis is pre-stenosis stage. So pre-stenosis stage itself, we may get the murmurs, but we generally don't get symptoms. So this patient has classical symptoms, so it is unlikely to be sclerosis. So I should be thinking of stenosis, AS, HOCM, and coronary artery disease. HOCM can be reasonably ruled out on clinical grounds with the symptoms, the murmur, dynamic auscultation observations. But coronary artery disease is something that you should always rule out before you conclude it as aortic stenosis and manage. Because with aging, most of us will have some degree of calcification of the aortic valve. But if the patient has a coronary artery disease, and if I replace the valve, this problem is not solved. He'll still continue to have the exertional dyspnea. He'll continue to have the episodes of syncope. He'll continue to have the chest pain or angina. So that's why we have to rule out the coronary artery disease. The best way to rule out, especially in a patient with aortic stenosis, you can't make him run on a treadmill. They already have exertional syncope, so he will run for a minute or so, and then he will have a syncope on the treadmill itself. Not very safe, especially when they already have symptoms of dyspnea and syncope. Asymptomatic, you
Right.
can make them run on the treadmill, but not the symptomatics. So we have to go ahead with a coronary angiogram. So before you take a step for the management of aortic stenosis, make sure that you've done a coronary angiogram. Okay. Now that most likely diagnosis is coming out as aortic stenosis, what would you like to do? How would you confirm your diagnosis now?
Sir, I think after this, I would like to go for first of all, an ECG, but to confirm the diagnosis, echocardiogram.
So if you get an ECG, then what findings you are expecting?
Sir, in the ECG, I think there will be visible left ventricular hypertrophy. There
Hmm.
would be also a left axis deviation.
Yeah. So classically, you're expecting a left ventricular hypertrophy, maybe with strain pattern and left axis deviation. Okay, but that does not conclude that we have aortic stenosis. It simply means that there is left ventricular hypertrophy and thus the axis is shifted towards left. It can happen because of hypertension as well. There are so many other causes. So conclusion should come only from echocardiography. Okay. So what information echocardiography is likely to provide you apart from establishing the diagnosis?
Sir, echocardiography will provide us with the area of the valve, of that particular valve. That is, I think, of the utmost importance here. It can also tell us about the pressure gradients across the valve and also about the left ventricular function.
Good. Yes. So these three are important factors to decide further management. Most important is the valve surface area. The next one is the left ventricular function and also gradient we use to decide for the severity. So what is a normal aortic valve area?
Sir, the normal area is around 3 to 4 centimeters.
And when I can count it as severe stenosis?
When the area has become less than 1 centimeter.
Less than 1 centimeter. For all valves, it is less than 1 centimeter. So that's very
Yes,
easy to remember. So even if tomorrow someone asks you, when do you call it as severe mitral stenosis? When it is less than
1
1 centimeter.
centimeter.
Though normal areas for each valve is different, severe is standard, that is less than 1 centimeter square. Okay. And now that we are concluding that this is a case of aortic stenosis, how can we manage it?
Sir, management is valve replacement.
Okay. So should I do valve replacement for all patients with aortic stenosis?
Sir, it is, I think, valve replacement is one of the major surgeries, but if the patient cannot undergo a major surgery, then transcatheter, I think TAVR can also be done.
Okay. Yeah. So I think you brought up a very important point. But before that, the question was, should I do valve replacement for anyone diagnosed with aortic stenosis? The answer is no.
Oh,
What guidelines recommend is that anyone who is symptomatic should go through valve replacement. Anyone who is having angina, dyspnea, or syncope because of aortic stenosis should go through valve replacement. There's a reason behind that. Because once you are having symptomatic aortic stenosis, your life expectancy is already significantly reduced. So after the onset of anginal episodes, the expected life expectancy is around 5 years. And after syncopal episode starts, it's around 3 years. And once there is dyspnea, it's around 2 years. So if I don't intervene, then already their life expectancy is shortened, so they may not live longer. If I intervene, I can extend their life expectancy. So all symptomatic should be subjected to valve replacement if they are not fit for the surgery, because it's a major open heart surgery. As you said, there is a limited invasive procedure, not a open heart surgery. It's called as TAVI or TAVR, transcatheter aortic valve replacement or implantation. But there's one important point. If you have a patient with aortic stenosis, he is not symptomatic, need not always mean they're asymptomatic. They can be pseudo asymptomatic. Because as you mentioned, no, this patient had exertional angina, exertional dyspnea, syncope also on physical activities. But what if I don't push myself to reach the point where I will experience the symptoms? So many times what happens is patients have aortic stenosis, but they have not pushed their body to the point where they can experience angina, syncope, or the dyspnea. Such patients, when we ask them, do you have shortness of breath? They will say no. They have never climbed 2 floors of the building. So they have not experienced the angina or dyspnea. They have not done any major physical activities to experience the syncope. But if I push them to that point, they will get symptoms. So such patients, we call them as pseudo asymptomatic. So that's why we have to unmask them. So how can I unmask them? We have to subject them to a treadmill test. They're reportedly asymptomatic, but once they come on the treadmill, either symptoms will appear or ECG related changes will appear. So if that happens, if I get an abnormal treadmill test, even when they are not reporting symptoms, I should go ahead with the aortic valve replacement. Age is a major deciding factor whether they will be deemed fit for the surgery or not. Most elderly, 80s, 90s, they may not be fit for the surgery. For such patients, we go for the TAVI or TAVR. Okay, so guys, I think we had a brief discussion on a valvular heart disease, considered as one of the difficult cases for the undergraduate students, the valvular heart diseases and the CNS cases. So we'll try to include more valvular heart diseases in the upcoming months, and also we'll go ahead with the CNS cases. Whatever points that we discussed today, these are the common questions that your examiners ask in your practical exams, or your teachers ask in your bedside examinations. So make it a point that you remember the questions and the answers that came up from me or Dr. Urvashi. अगर यही रट के आप चेप दोगे आपके एग्जामिनर्स के लिए काफी है, you can come out with flying colors in your exam, right? So that's it from us today. We will be signing off now. I'll see you in another 10-15 minutes on the other side. We will continue with one more topic on the redaction series. Dr. Urushi, thanks a lot from the MEDEC team for such a wonderful presentation.
थैंक यू सर, थैंक यू सो मच। और जो पॉइंट्स आपने बोले वो क्लिनिकल पोस्टिंग के टाइम तो बहुत इंपॉर्टेंट होते हैं। एंड लाइक यू सेड, इंपॉर्टेंट पॉइंट्स ये रट के भी बहुत कुछ हो जाएगा।
So hope this series is helping you guys. And if you want any particular case for us to bring, we will try to include them. Just let us know through social media or Instagram or the Telegram, and we will try to include those cases in our discussions in the subsequent series. Okay, guys. So see you in the other side. We will have adrenal physiology class soon. Till then, bye bye. See you.